So, welcome everybody to our closing keynote, Beyond the Physical Wounds, the Psychological Impact of Injury. Really excited for our closing keynote. I do just want to remind folks that after we wrap up our closing keynote today, we do have some closing remarks, so invite you to stick around. We'll stay here in this room. But before that, I would love to introduce our speaker, who is Dr. Sydney Timmer-Murillo. Dr. Timmer Murillo is an assistant professor of surgery in the Division of Trauma and Acute Care at the Medical College of Wisconsin. She completed her PhD in psychology at Marquette University and her residency in clinical health psychology and fellowship in trauma and health psychology, both at the Medical College of Wisconsin. And as a psychologist, Dr. Timmer Murillo's research includes examination of the individual biological, physiological, and socioecological factors that contribute to mental health outcomes after traumatic injury, with a focus on interpersonal mechanisms of trauma. Her work also includes enhancing interventions provided at trauma centers to promote comprehensive care, such as trauma-informed care and mental health integration. So welcome, Dr. Timmer Murillo, and I will go ahead and have you share your slides.
Sounds good. Let me do that. There we go. Okay. So can you see that all right, sir? If you
Yep,
don't mind
looks
jumping
great.
in.
Yep,
Beautiful.
looks
Okay. So thank you all so much for having me. I am so excited to be presenting today after such an amazing group of presentations already, and really looking forward to discussing the psychological impact of injury. So first, I have no disclosures. But today, here, one second, let me move you guys so I can see a little better. Okay. So today I am speaking to a group that I know understands deeply the profound impact of injury, its societal costs, and the ripple effects it sends through entire communities. However, my aim for this talk is to really zoom in and narrow the lens and focus on the individual experiences of those who have suffered injuries. So, by doing so, I'm hoping to highlight really the immense psychological toll that can often follow injury and paint a clearer picture of the mental health challenges that these individuals can face. And so ultimately, I want us to consider really the drivers of mental health disparities and reflect on how we can integrate mental health into our prevention efforts by addressing not just the injury itself, but also its long-term sequelae. And ultimately, we can better mitigate this psychological burden and improve trajectories or pathways of recoveries for those most affected. And so to begin, I want to share a bit about myself because on the surface, I might not appear to be an injury prevention researcher. So, as Dr. Kolbeck said, I am a licensed clinical psychologist, and throughout my training and my career, I have been a mental health researcher with a particular focus in emotion regulation and affective science. And yet my path shifted towards trauma and injury and mental health treatment because I recognized really the profound need to help people navigate traumatic events and specifically these events that turn their worlds upside down. So in my role, I work one-on-one with patients in the hospital right after injury to help provide brief intervention to facilitate coping, but then I also see people after they leave the hospital, and I do individual psychotherapy to help address really any ongoing mental health needs that somebody might have. And so, like I said, while I don't initially describe my work as injury prevention, the further I advance in my career, both within research and in clinical practice, the more I see how my work contributes to really the grassroots levels of secondary and tertiary prevention as I work ultimately to try to shift the trajectories of recovery for my injured patients, trying to create meaningful change that can ripple outward in their life after injury. And so there's me. To ground this discussion in lived experience, I want to start with a case example of someone I worked with here at Freighter and the Medical College of Wisconsin. So, my patient is a single man who identifies as Black or African American in his early 30s. And he was shot after being set up by his own brother. And so he had the best work ethic I've ever seen. He was a business owner and a mechanic who had a deep passion and talent for working on cars. And his dispute stemmed from a conflict with his brother's girlfriend's family after he fixed one of their vehicles. And so in the hospital, this man experienced profound and really understandable anger and rage at what happened to him. And I'll kind of return to his case throughout this presentation. But what really stands out in his story is that, he wasn't simply someone who was just injured out of the blue and underwent surgery for his injuries and then walked out of the hospital doors. His injury and really the trauma that surrounded it continued to reshape his life. And he stopped working, he isolated and really kind of socially withdrew from his family. He found himself ultimately living a shadow of the life that he once had. And, I think his story underscores really the importance of primary prevention, right? To prevent injuries like this from happening in the first place. But it also raises a critical question of what are we missing in addressing the accumulating side effects, the emotional, mental, and social or psychosocial things that an injured patient experiences.
Hey, Sydney, I just want to let you know your screen is frozen, so you might just want to turn off your camera.
Oh no, let
Yeah,
me
it's okay.
do that right now. Let me see here. Can you still see my slides though?
We can and we can hear you, so
Okay, good. Okay, sorry if that was a bit distracting.
no worries.
Okay, so when an injury happens, what is the psychological landscape that somebody might experience? To start, I think when we consider traumatic injury, typically most consider post traumatic stress disorder, PTSD, first from a mental health perspective. And while the general population has a 5% incidence of experiencing PTSD annually based on any type of trauma exposure, sustaining injury during trauma immediately elevates PTSD to about 20 to 30% of the injured population. And PTSD, in addition to the physical injuries sustained, really does carry significant consequences. And so I want to kind of paint the picture of these kind of core symptoms that you might see of PTSD. So the first being intrusive symptoms. So that is, classic things like flashbacks or nightmares. And in particular, for my patient, he had quite severe nightmares. He also, you can experience avoidance behaviors. So, working really, really hard to avoid people or places or situations that might remind you of the trauma, as well as just working really hard to avoid even just your thoughts that might connect you back to that traumatic injury. People can also experience negative alterations in mood and cognition. So, thinking like, I can never trust anybody anymore, even my family, or having really strong rage or shame or guilt. And then lastly, individuals can experience hyperarousal. So that's things like not sleeping, being very vigilant or on guard, increased jumpiness or startle reaction. And so for my patient, this was particularly impactful that he could not relax. He had security cameras on his home and he was quite literally checking them constantly, even throughout the night, to make sure that he was safe and there weren't things happening outside. And so, as you can imagine, having these symptoms makes it incredibly hard to reintegrate back into society in the same way that one did pre injury. And PTSD is also often chronic. So in some studies, it's associated with 40 to 50% increased risk of being on disability. Up to 50% of those with PTSD endorse chronic pain, and up to 46% may go on to develop a substance use disorder. And so you can see the ripple growing and how it impairs recovery and likely increases one's chances for negative or other negative outcomes. And yet when we think of trauma, our our minds do jump to PTSD, but there are really other important psychiatric conditions that individuals are at risk for. So depression has an 8% incidence in the general population, yet estimates show that it can be up to 33% in injury patients. And so if you think about somebody who maybe has sustained or permanent changes in functioning after injury, or perhaps their role changes in their family or at work because of their injury, this really can change their sense of self or their confidence, and that can lead to depression or sadness, a sense of helplessness about their situation or hopelessness in the future. And then comparably, anxiety-based disorders such as generalized anxiety can also begin to manifest after injury. And we see this particularly with anxiety about psychosocial stressors from the injury. So things like lost wages may be increasing their anxiety about their financial situation, insurance stressors, or if they were injured at work, dealing with workers' compensation cases, I see often, as well as individuals who really fear re-injury or experiencing another trauma. And so maybe that means they're limiting their engagement in activities where they think they might get injured again. And then if they have a permanent disability, they can often worry about, how this is going to affect them in the future. But lastly, individuals can also have existing psychiatric conditions, which can be exacerbated by the injury itself. And so, take a recent patient of mine who had a history of really largely treated and controlled obsessive compulsive disorder. Yet, after her injury, her obsessions and compulsions worsened and then became centered on recovery, and really engaging in checking behaviors where she was seeking excessive reassurance from doctors or family members that she was recovering as normal, that things weren't problematic, and that she wasn't going to have any setbacks in her recovery. And so, mental health is really a vital component to consider after injury, as the injury really can shape somebody's mental well being. But, in fact, one thing I want to clarify is the vast majority of individuals actually go on to adjust and do fine from a mental health perspective. So, research led by Dr. Tomas from our team or Thomas at MCW, among other institutions, have evaluated, just what are those mental health trajectories or pathways across time after injury. And the research shows that most injured patients fall within a quote unquote resilient group. And so they're endorsing relatively low symptoms right after injury. And then those symptoms stay low across time. And then there's another group of individuals who have what we call remitting symptoms. So perhaps they do start a little bit higher in terms of their poor mental health. They're a little more distressed. But again, over time, they just see this natural improvement in their symptoms. But there are two groups of patients that we see, and those are individuals who have chronic psychopathology. So they start with higher symptoms of PTSD and they stay high, or individuals who have worsening psychopathology. So they have some symptoms to some degree, but they continue to climb over time. And so, knowing that there are these individuals who may be at risk for going on to continue to experience distress, taking that public health lens, we want to ask, why are some individuals at greater risk than others for expanding negative sequelae? And with that, how do we develop programming to find out who's at risk and meet their needs in order to really try to reduce the impact of psychopathology in our injured patients? And so while we see that there are these very real experiences of distress for many individuals after injury, that risk is just not uniform. And so I want to dive into some of the research that we've conducted at the medical college. But to give you some context about our research population, so as some of you may know, Frater is the only adult level 1 trauma center in southeastern Wisconsin. And this side of Wisconsin, I think, is so interesting geographically because as we work with patients, they're from such geographically diverse backgrounds and needs. So we get individuals from rural Wisconsin, while we're also working with individuals in our urban area of Milwaukee and Racine. And so while a primary mechanism of injury is falls and motor vehicle collisions, like so many trauma centers, our proportion of gunshot wounds and firearm violence is quite high. And so that also ultimately ends up playing a big role in the work that we do and what we see here at the trauma center, which I'll discuss in a little bit more detail later on. And so within our research, we primarily look at adults who sort of fit this bill in terms of injury, yet we do tend to oversample Milwaukee residents, and I mean the city of Milwaukee, and individuals who are of racial or ethnic minoritized backgrounds to address other kind of important socio-contextual factors, which we'll talk about in a little bit as well. And so looking into the research, so we see that there are those different mental health trajectories or pathways. And we know risk is different for what lands you on these different pathways, but we didn't always know why in the research. And so one way that we can look at this within mental health literature specifically is that we think about trauma through this peri or pre-peri and post-trauma lens. So there can be pre-trauma risk factors, so things that might influence somebody even before the injury happened. So that would be things like demographic factors or socio-contextual factors. Then there can be peri-trauma risk factors, or what happens during the injury event itself that might put somebody at risk for psychopathology. And then what are the post-trauma risk factors that are things that might happen after the injury that might sustain somebody's risk as they kind of go into recovery and move through recovery? And this is something that we evaluate clinically as well with a screening measure that was developed at our institution called the Injured Trauma Survivor Screen. And this specifically looks at risk for going on to develop post-traumatic stress disorder or a major depressive episode using these sort of pre, peri, and post-trauma categories. And so this is a 10-item yes/no measure with each item or the screener as a whole showing excellent sensitivity and good specificity. And so a lot of my initial work evaluated this injured trauma survivor screen or the ITS with a focus on really what happens during the event, during the injury or that peri-trauma period. And the reason being is, as I was seeing patients in the hospital, I was continually struck by really the emotional impact that perceived life threat or in the traumatic moment, did they think they were about to die, as well as the experience of intentionality in the injury had on somebody's mental health. And indeed, when we conducted research in our adult sample looking at how people responded to the ITS, we found that really across the board, when somebody felt that their injury was intentional or when they thought they were going to lose their life, these were the strongest predictors of PTSD symptom severity 6 months down the line. And so, then I wanted to dive more into intentionality because of what we saw. And so, bringing it back to my patient, one important part of his story is that when he was initially shot in that dispute that I mentioned, it was because his brother set him up. And so, for my patient, he felt that profound betrayal, specifically from his brother. And, for him being shot, and really in the month after that, even while engaging in physical recovery of his injuries, it was the betrayal that really was the driving force of his emotional distress and struggle, more than any other piece, more than the pain, more than kind of any other thing about being in the hospital or frustrations and his limitations. It really was that betrayal. And we see that with interpersonal violence often. And so interpersonal violence and injury is just a vital kind of category to consider when it comes to injury and mental health. And what we found, taking our research a step further from what I just shared, is that when we categorize patients based on them experiencing both an assaultive trauma, so whether they were shot or experienced a blunt assault or a different penetrating trauma like a stab wound, and if they experience that perceived life threat during that assaultive trauma, you can see here that individuals have persistently elevated symptoms at baseline across to 6 months post injury. And in these two graphs, it's specifically looking at those avoidance symptoms and hyperarousal. So if you have both of those experiences relative to other patient groups who either have one or neither of those peri-trauma experiences, you're more likely to have hyperarousal, hypervigilance, and avoidance. So, put another way, these individuals likely do not feel safe, and they're trying to work really hard to avoid any potential threat while they're being hyper attentive to any sign of danger. And so for my patient, he absolutely did not leave his house unless he was coming to see me. And with his injuries, he felt extremely vulnerable, and he was watching those cameras 24/7. And so every time I did see him, when he would come in with these new situations where he thought he saw a potential threat to his safety. And it again reinforced his sense that he couldn't leave his home, and it really exemplified why he continued to struggle with his mental health, was that avoidance and hypervigilance. And so we've continued to extend this work to try to just underscore to health systems that assault or interpersonal violence really carries this added risk compared to other injury mechanisms. And so we've showed, compared to non-violence mechanisms in a sample of over 200 patients, that those who do have violence-related injuries have higher symptoms of PTSD initially, and they're just not going down with time. And in fact, they're increasing toward that diagnostic threshold of PTSD, whereas non-violent injuries, as you can see here, kind of remain in a subclinical range. And further, to show that it's more than just PTSD, we've also showed that this same sample, their levels of depression and stress are increasing with time as well. And their anxiety is staying chronically elevated. And this is all relative to nonviolent injury patients. And so, this group who experiences violent or assaultive injuries is really burdened by a host of mental health symptoms that can be complicating their recovery. And yet, across the US, there's been no enhanced care for these patients in trauma centers, and there's kind of no standard practice for how to address these important mental health needs for patients. And in addition to interpersonal violence more broadly defined, we've also focused in it as a whole team on firearm violence. And the reason being because of our trauma population and how it does gunshot wounds or firearm violence does make up a significant proportion of our population, but also because our team has navigated really countless stories like my patients. And yet, for a long time, we haven't had kind of systematic services to meet their holistic needs until we started to make changes. And so, as I'm sure you all know, given some of the limitations in funding to examine firearm violence for a long time, there is also just a profound gap of research that looks at survivors of firearm violence and, in particular, their mental health outcomes, as well as particularly prospective self reported data on their mental health experience. And so, with that, we published this last year, simply just presenting the rates of mental health outcomes for firearm violence relative or survivors relative to the general population in order to begin getting our data out there that this is a population that really needs more attention. So our patients are having higher rates of psychopathology than even what I just presented for assaultive patients, and in particular, PTSD and anxiety, though depression and stress continue to climb by 6 months. And further, we're also trying to demonstrate, how this connects to physical health and quality of life to really help show trauma centers why this can matter beyond mental health too. And so we've assessed physical health related quality of life. And that's, for those of you who don't know, just how somebody perceives how their life is impacted by their health and how it shapes their view of the quality of their living and functioning. And so in this work, we've demonstrated that their quality of life is well below that of the general population shortly after injury, which is something you might expect if somebody's experiencing injury. And yet, importantly, it doesn't improve with time. So even with the potential improvement of their physical injuries, they continue to endorse a lower quality of life as it relates to their physical health as well. And then to really hit it home, as you can see, we're trying to drive this message across of why this group matters and why they might be at greater risk. We've compared firearm violence survivors to our MVC patients or motor vehicle collision patients from a mental health perspective. And so I just want to clarify, this isn't to say that survivors of other injuries don't matter or aren't at risk for mental health outcomes. It's just that we're trying to exemplify that this is a particularly at-risk group, and we certainly see and treat individuals who've experienced other mechanisms of their injury. But in this particular project, this was data we've presented at the National Firearm Violence Research Conference, and we've compared firearm injury survivors to motor vehicle collision survivors. And again, looking first at PTSD symptoms, you can see that our firearm violence patients are endorsing higher symptoms of PTSD, which are increasing with time. And then, when you look at their baseline experiences of anxiety and depression and stress, what you can see here is that at face value, initially after the trauma, and we assess typically about 2 weeks after the trauma, both groups seem fairly comparable in terms of how much anxiety, depression, and stress they're endorsing. So they might look similar afterward. And yet, when you look 6 months later, you can see that our motor vehicle collision group has had that sort of natural decline in symptoms that we see with those remitting pathways that I talked about at the beginning. Whereas our gunshot wound patients are continuing to endorse significantly elevated symptoms across the board. And so this really shows the importance of really how are we considering the screening that we do for mental health after trauma? Because initially patients may present similarly from a symptom endorsement perspective, and yet their pathways and risk for progression of worsening symptoms are different. And so we need to be particularly thoughtful that, these symptom presentations do in fact go on to be distinct, and we need to be trying to predict and then provide early intervention as a preventative effort for those who are impacted. And so, again, just trying to ensure that our healthcare systems hear us, we've continued to show that our firearm patients do have worse physical health relative to another injured sample. And this is across time. And again, controlling for injury severity and tying this to physical health and extending it to pain, we see that our firearm injury patients have significantly worse pain severity, and that they endorse that their interference of their pain in their day-to-day functioning is also greater at 6 months, irrespective of their injury severity. So even when we control for how that injury impacted them, by 6 months, they still have this interference in their functioning. And so I think generally in this day and age, we know the importance of mental health. And I've shown you maybe a concerning picture of these mental health outcomes, in particular for certain at risk injury populations. But from my clinical lens, I just want to make clear just how impactful mental health can be after injury. And so I have two examples here of how PTSD and other symptoms like anxiety can affect somebody's recovery post injury more broadly, and through it either affecting maybe the spread of violence and or it leading to an increased risk of re-injury. So take for instance my patient. As I shared before, he was dealing with that betrayal coupled with ongoing fear for his safety in his relationships, and he was having a particularly hard time regulating his emotions in response to the situation. And so, again, we understand why he would be feeling these ways, but it really was impacting his ability to cope. And so, in the hospital, this led to a lot of homicidal ideation from my patient. And he had a really strong desire to retaliate due to both the betrayal but also the continued fear he had that he wasn't safe. And so, if he had acted on these homicidal ideations, violence would have spread, and it would have had the potential to spread either through others getting hurt or him getting hurt again. And again, we could see that the cycle of violence would have continued for my patient and in our community. Another presentation we can see is if somebody is highly avoidant and fearful that they might experience another trauma, what we so often see is that they then isolate from anything and everything that is reminding them of the trauma. And so, with those symptoms, what we tend to see is that if somebody is wanting to avoid trauma reminders, they're typically not wanting to come to our appointments and they're not engaging with maybe their primary care provider or physical therapy. And on top of that, not only are they like fearful of complications, but they're fearful of just having another traumatic experience. And so they're withdrawing and not engaging in much physical activity or their treatment recommendations. And so that can influence things like pain or increase their risk of having complications. And ultimately, you could see the risk of re injury or complications rising as it relates to their physical recovery. And yet, there are so many more ways that mental health can affect people than these two that I'm mentioning. So, as I said at the start, with PTSD, it's associated with substance use later in life, or individuals might be at greater risk for later self inflicted injury. And so, we need to address mental health not only for the sake of mental wellness, but also for its intricate connection to so many different facets of health and life. And yet, I think I would be doing a massive disservice to us all if I didn't acknowledge context. Because it's like what I say to my patients, their injuries don't just occur in a vacuum. They've had all of their life stuff before the injury and how that shaped them. And they've got all of their life stuff when they go back and get out of the hospital or leave therapy for the day. And this can be in both good and helpful ways and bad and harmful ways. And so, just as Dr. Marshall shared at the beginning of our day and highlighted in her keynote, it's paramount that we put health disparities into context. And a lot of our research really relies on the socioecological model and how we ground our research in our research collaborative here at MCW. And so the socio-ecological model really allows us to center the individual and their mental health, as well as all that they bring to the table in terms of their individual traits and their psychosocial factors or demographic factors within the spheres that influence them and their health. So thinking about their interpersonal or familial contexts, to the community context in which they live and in societal contexts. And so we all know how these contextual factors can encompass so many social determinants of health and so many different domains of health. And so it would absolutely influence injury and somebody's mental health. And in particular, things that we've looked at are community violence context and history of racism or discrimination. And so, as we are in Milwaukee, one of the most racially segregated cities, we've examined how somebody's history of racism and discrimination can shape somebody's mental health recovery following all injury. And so, in a study led by my colleague, Dr. Tim Geyer here, we've looked at a sample of Black injury patients. So, again, this is not just assault or interpersonal violence, but all mechanisms of injury. And we found that experiencing discrimination by law enforcement officers in one's past is significantly predictive of lower physical quality of life and higher PTSD in our individuals living in Milwaukee. And so bringing it back to my patient, he had a history of racial profiling by officers, and this didn't just happen pre injury, but it also complicated recovery as he continued to be stopped by police officers an additional 3 times just during our course of treatment alone and experienced discriminatory behavior that again reinforced and really increased that sense of threat from his context in addition to the trauma that he had just gone through. And so this points to the need that we must account for this as we care for our injured patients and think about their mental health and sense of safety. Similarly, in another study using kind of registry data and neighborhood level data of predominantly Black motor vehicle crash survivors, we assessed exposure to community violence, including gun violence, from the time of the crash to about 6 months later. And we found that there was an astonishing 54% who were exposed to firearm violence, and that exposure increased their risk. And I should say, exposure to community violence increased their risk of going on to experience or be at risk for experiencing PTSD. And then taking this beyond injury, just because we were seeing these patterns, we've also wanted to understand this exposure to violence in our Milwaukee community more broadly, just to understand the magnitude of the problem for anyone who may ultimately come to receive healthcare at Freighter. And so we looked in a community sample of 400 Black adults who were recruited from a community action agency where we were collaborating on a group project looking at poverty and systemic discrimination. And what we found is that every single participant from this community sample experienced at least one violent event in the past year alone. And that was just frequency, but to give averages, over 40% endorsed hearing gunshots in their community. um, Individuals endorsed seeing community violence 10 times, on average, seeing it in social media 7 times, witnessing other violence related events 10 times. And they themselves were survivors of violent incidences on average 4 times. And this is hugely important context. If people, even outside of injury, have this heightened exposure to trauma and violence, how could it not shape their experience if they do ultimately come to the hospital following injury and then shape their experience of outcomes? And so, with all of this data, we must ask ourselves, what do we do about this from a mental health perspective? Um, I'm a clinician, and so much of my work is one-on-one with patients. And yet, we can't simply just witness this picture of risk and say, for my injured patient, I'm going to treat him the exact same way that I would treat, any other person in spite of his risk and social context and not acknowledge that. I can't just provide, standard care and standard PTSD treatment without acknowledging those contextual factors that shape his life and shape his risk for experiencing a host of negative outcomes. I have to consider that and how I'm working with him and acknowledge his lived experience. And so this is where you really can see how we can model mental health intervention and work using a prevention model. So taking a lens of secondary prevention, we can provide treatment in the hospital for all at-risk patients by providing that early mental health screening and intervention as that form of prevention of worsening symptom severity, or even just the development of psychopathology. And then similarly, we can take a lens of tertiary prevention and think to ourselves, if psychopathology is developing and does go on to develop, then how do we consider how we reduce treatment barriers for our patients to get them the care that they need for their mental health? And also, how do we care effectively for them? How do we address their unique needs so that we can target and treat their own unique concerns that are based in their risk factors and their mental health symptoms? And so, with that, trauma centers must acknowledge the real risk of psychopathology after injury and then incorporate steps to acknowledge it in their standard of care. Unfortunately, the American College of Surgeons, 2 years ago now, the Committee on Trauma now mandates that all level 1 and 2 trauma centers develop protocols for screening for mental health and then have a protocol for how to provide referrals to treatment for mental health post injury. And that can be pretty broad in what the referral looks like. But fortunately, in our institution, we've had our psychology service for a decade now, or over a decade now, providing early intervention to injury patients in the hospital. And we've been using that screening through the Injured Trauma Survivor Screen since 2017. And while this is certainly an important example of a model and one that we would propose can really help us cast a wide net in order to catch who may be at risk, as I've highlighted from the data before, there really are disparities in risk across injury, and certain groups, particularly those with firearm violence injuries and interpersonal injuries, or those who experience that socioecological disadvantage, those groups necessitate us considering if we need to do more or tailor care to meet their unique needs. And so, probably the work I'm most proud of is our model or framework that we have and developed for firearm violence care that I led along with my team of other psychologists and surgeons and nurse practitioners and ED physicians to essentially put out a call for all trauma centers to do more for our patients who were injured by firearms. And so this is the framework, and we modeled it essentially after this pre, peri, and post trauma risk that I showed you earlier, but ties it specifically to firearm injury and then the health care that we provide. And we really aim to provide real, concrete, actionable items that trauma centers can implement to improve their standard of care for firearm injury patients in this expectation that this has the potential to reduce risk of spread of violence, reduce psychopathology, and other potential complications that can arise in the recovery period. And so let's dive into it column by column. So first, we must acknowledge that context that I shared, highlighting that, taking that socioecological lens, if we assess for trauma history or history of discrimination or neighborhood contextual factors, this is going to inform us of how best to tailor our treatment to this patient. And so for my patient, for instance, knowing the area of Milwaukee in which he lived gave significant context to me that my patient was not only injured in this community context, but was going to be discharged back to an area where he doesn't feel safe. And there's also data to show that it is a neighborhood with high rates of violence. And so, in addition to that, he also had that history of police discrimination and felt targeted in ways that might limit his sense of safety. And so it shapes our understanding of his experience. And further, again, as so many have already highlighted today, we must also consider these key social determinants of health and screen for them so that we can get patients connected to resources that might be important in mitigating risk for poor outcomes. Now, moving into the care that they receive at the hospital. So, there is so much that we can do to use the hospital period as a time in which we can reduce risk and increase access to comprehensive care. And so, in our hospital, we really see the sheer benefit of a multidisciplinary team using expertise to provide holistic care. And so, again, here we provide that mental health treatment while patients are inpatient. And this is so vital for patients who are struggling with coping with their injuries. So, for a violence related injury patient, it may be that we're helping them navigate ongoing safety concerns, or perhaps we're getting them connected to our local intimate partner violence center for resources. But for unintentional injuries, let's say, we can also provide that intervention to help mitigate PTSD development in the hospital. And so that might look like, helping a patient who did experience a car accident overcoming their fear of getting back in the car, since they know that they have to get in a car after discharge, and helping them do that and give them tools to do that. And so this is really just examples of how enhanced care can address holistic recovery. Furthermore, our model tries to exemplify how vital taking this approach is for promoting collaboration across team members. And so for my patient, when he was first injured, I co-treated him in the hospital with our hospital-based violence interrupter. And this was absolutely fundamental, since at least initially he had that pretty significant homicidal ideation and desire to retaliate. So, by working together with my colleague, she was able to be a credible messenger, talking him through that urge to retaliate, while I could also provide emotional support and help him regulate his emotions and build a connection with him in the hospital, and also help him really stay centered in his very significant injuries. And he didn't always work as effectively with other team members, but I feel pretty confident in saying that, without her and I working as a team and working with him and connecting with him, he really could have left the hospital and acted on those thoughts, and yet he didn't. And I think it was in part because we had these services available to him. And then ultimately, we need to expand our continuity of care and provide firearm violence survivors with longer term outcome or longer term recovery, based really on these data that I presented, that their symptoms are worsening with time. And so, with that, we have an amazing outpatient team that's led by Doctors Colleen Trevino, who's an advanced practice provider here, and Terry Jerome Cassini, who's our lead psychologist and the director of our Comprehensive Injury Center. And when patients sustain a gunshot wound now for the past several years, or I should say, before I even go to our clinic, you might be surprised to know that nationally, there's no standard follow-up care for firearm violence survivors. So not everybody gets followed up after discharge. If they don't need sutures removed, or if they don't have any follow-up needs by our surgeons, most often people are told to, go follow up with their primary care provider, despite us knowing that most firearm violence patients don't have one. And so they're kind of left hanging. But since 2020, here at Freighter, we have this clinic led by these two individuals where every single firearm injury patient gets at least one follow-up appointment with our multidisciplinary team. And so from there, we can begin to monitor on the outpatient side their mental health needs, but also connect them to our longer term clinic if needed. And that really does reduce a significant barrier in accessing mental health care. Further, by doing things in this way, we can also normalize mental health treatment and frame it as just a standard aspect of care in order to destigmatize mental health treatment and talking through your mental health needs. And then we also can address our social determinants of health by through multiple team members. So with our psychology team, but also we have social work who sees them, and we have that violence interrupter continue to see them on the outpatient side as well. And so again, with my patient, it started off a little rocky. He would miss appointments when he was discharged from the hospital. He might have come in inebriated a couple of times, and he didn't always trust everybody, but he continued to come. And I think that's what matters. And he continued or started to see improvements and really get the care that he needed. And he wouldn't have gotten that care in a traditional medical setting. He likely would have been penalized for missed appointments, and he probably wouldn't have felt heard all the time. And so having this multidisciplinary team, I think, allowed him to just slowly start to build trust with us, because we were addressing all these important aspects of his health and wellness. And so, furthermore, we also need to consider, and this is a piece of our future research, how we provide long term mental health care for our patients who, empirically based PTSD treatments might not fit correctly to their needs. Um, Many of you might not know this, but with PTSD treatment, typically the research says, you must systematically, quote unquote, have your patients face their fears and face the trauma reminders. Yet for firearm injury patients or patients living in contexts with high violence, and they continue to experience real threat, that doesn't really work, that systematic facing of your fears, or you got to be really creative in doing it. And so we have to progress our research to develop these culturally adapted treatments that might fit their needs and their lived experiences better. And yet, while maybe this model, in my humble opinion, seems clear and linear and has these action oriented items, we're up against a lot of structural discrimination in societal context that does influence prevention efforts in a real way. And one of the saddest points of my career to date is when, after not having seen my patient in probably about 8 months after he was discharged from my care, I found him back in my ICU after being shot again following a different dispute. And, it really showed the depth of our problems and the pervasiveness of violence in our community and, how far we have to go in terms of addressing firearm violence. But, one thing I think it exemplified also is that we were maybe on to something, or we are on to something when it comes to comprehensive care, because, that second time around, the relationships that we built with him were there. And, I was really shocked by his motivation to get things back on track. It didn't go the same way that it did the first time. He didn't come in inebriated. He didn't miss appointments. He was attending those appointments regularly. He found his footing more quickly, and he worked with the team in a way that kind of met his needs faster and had that rapport that was different than the last time. And, I think it's because we ultimately were aiming to treat him as a whole, a whole complete person. And that's really what we're trying to do, is recognize all of the ways somebody's impacted by injury. And so to conclude, kind of taking this collectively, I hope that this work exemplifies just how vital it is to incorporate mental health into the picture when we think about injury prevention. Injury doesn't end with the physical wound. It kind of reverberates through somebody's life and through their family and communities. And by acknowledging mental health as really inseparable from their physical recovery, we have this opportunity to change the trajectory of healing and try to reduce suffering and increase somebody's well-being. And my patient's story highlights what's possible when we do prioritize comprehensive care by providing that appropriate screening, getting that inpatient support, connecting to multidisciplinary teams and follow-up. And yet, our healthcare system or our group and the few others like us can't remain the exception or the outlier of care. It really has to become the standard of care for all trauma centers across our country because when we address mental health after injury, we're not just treating that wound or those symptoms, we're helping patients really try to rebuild their lives. And that ultimately should be the key metric of our success at trauma centers. So I want to thank you all so much, and huge thank you to our massive collaborative group and our team who shares the same passion that I have, and make all of this work possible. And I also want to thank our funders. So thank you to Advancing Healthier Wisconsin and the National Institute of Mental Health for funding much of this research that I shared today. All right. And
Awesome.
stop sharing, and then I can try to
Yeah.
put my video on so that I can answer, but if it's distracting, I can take my video away again.
Right. We do have a few questions in the chat.
Okay.
We've got about 4 minutes. So the first question is from Nadav, and it's is resiliency associated with socioeconomic status?
Yeah, so that is a great question. And I will say that relationship, like so many other things when it comes to mental health and socio-ecological context, is that it's more complicated than just saying, is there a one-to-one pathway? But, when somebody does have more resources and more available to them, that does give them kind of certain advantages, right? And helping them cope through things. And so it can help their resiliency. And yet, we can also see that individuals who maybe come from a more disadvantaged background, it's not that they're not going to have resiliency. They bring a lot to the table, and there are a lot of individual level factors that can help them be resilient in spite of their context. So hopefully that answers your question.
Great. Thank you. And then Stefan mentions the intent of firearm injuries treated in hospitals is often
Mm.
misclassified. How do you verify the true intent behind firearm injuries?
I appreciate that note so much, and I agree with you that especially in registry data, it often is misidentified. A lot of this work, if not the vast majority of the work I just shared today, is the patient's report. And so for them, using that screener that I mentioned, the injured trauma survivor screen, we ask them, "Do you feel that this was intentional?" And often that's like the biggest thing is their perception of it, because you can even have somebody who was in a motor vehicle collision say, yep, I felt that person, that driver next to me, swerved into me on purpose. And that's going to shape their recovery, their perception of their safety differently than, somebody else.
Thank you. A couple more questions. Is there a significant difference in physical damage and healing between firearm patients and MVC patients?
Yeah. So I would say within injuries, you can find that there's a within injury or within mechanism variability, just like there would be variability across different mechanisms of injury. So certainly, with a penetrating injury, there can be a really severe physical damage and lots of organ systems involved. Or you could have a firearm violence patient, and we see them often where it's just a through and through injury or a graze wound. And so that might be a less severe physical injury. So there is a lot of variability, and what I'll say is that we control for that. Injury severity score isn't always the best measure of injury severity, but it can be a proxy of how bad the physical damage is.
Great. And then one more quick question. How do you view the support of the Trauma Survivor Network through a trauma center?
Yeah, that is a great question. I appreciate that. And I will own that I am less familiar with it in my own institution. We do have that network, and it does provide monthly support to trauma survivors who want to access it. I think that, as I shared in terms of how important multidisciplinary teams are, my philosophy is it takes a village, right? When it comes to healing and recovery, or really anything in life, is that the more support, especially when it's the right support that you need, the better. And so I think that the Trauma Survivor Network can occupy an important piece of the recovery process, particularly for people who want that peer support. Um, but in terms of like the ins and outs of it, I am less familiar with it.
All right. Well, we have reached 3:15, so we're at time for the presentation. But I just want to say thank you again to Dr. Timmer Murillo for just an amazing presentation about mental health after injury. I think a great way to cap off our conference today. So thank you so much again
Thank
for
you
that
so
great
much.
presentation. Really appreciate it. And just to wrap up, just a few closing remarks. So it's been a pleasure to host this year's conference as the representative from Wisconsin. Just really, really appreciate all of the work of the conference planning committee and all of our speakers and panelists. I want to shout out Heather and Chris as well, who really did a lot of work behind the scenes pulling together this conference. It would not have happened without you both. So thank you so much. Just a couple of things we want to mention before we close for the day. So you will be receiving an email with a survey, an evaluation for the conference, and we would appreciate it if you could just please take a few moments to complete that as we're planning for the 2025 MIPA conference. We do definitely look at those evaluations and take into consideration ideas and suggestions that folks have. So please do complete that survey. As I mentioned earlier as well, our videos and resources and slides will be up on the MIPA website, so please watch for those after the conference concludes today. And once again, we do encourage you to sign up to become a MIPA member if you are not already a member, and to also get involved in our committees. Again, you can sign up at midwestinjurypreventionalliance.org. And if you have questions, you can contact info@midwestinjurypreventionalliance.org. And like I said, we're happy to, as Wisconsin, to pass the virtual torch to next year's hosting state, which is to be determined. But we'll still be here to certainly support you all. And with that, I will turn it over to Nicole for some final closing remarks.
Thank you, Sarah. And just want to underscore your comments around thank you to Heather and Chris for working the background, and also the wonderful presentations, and really had me reflecting on the entire environment and how, as injury prevention practitioners, it's our job to be aware, understand health equity, disparities, and also how it impacts our community. And in there, in each of the presentations, I also noted that the presenters gave us action items to learn more about ourselves as a person and how we're approaching injury prevention. And so, as we noted earlier this morning, the Midwest Injury Prevention Alliance is an organization of injury professionals that work collaboratively to reduce unintentional and intentional injury related to death and disability. We facilitate development of a coordinated approach for unintentional and intentional injury prevention and control in the region. We develop and share injury prevention planning, evaluation, education, and policy strategies, training, research, and other initiatives among members of the MIPA network. We foster collaboration and communication. Thank you again for joining us today. Thank you for doing all you do and helping us move injury prevention forward. Have a great day and see you later.